All right, we're going to go ahead and get started. I'll be continuing our lecture series on spinal cord injury medicine. Today we're going to be talking about neurogenic bladder after spinal cord injury. As we're going through, if you have specific questions, feel free to put those in as a chat and or raise your hand, although I don't always see the hands raised as we go through this. So we're going to talk through first definitions because I think that's an important place to start. We'll talk through a little bit of epidemiology and then review the anatomy and physiology of bladder innervation. The neural innervation becomes very, very important to this population in particular. We'll talk through clinical evaluation as well as management strategies. So again, the topic of bladder management after spinal cord injury was one of the late comers actually in terms of management opportunities, and it was in the 70s and 80s that we first began to use intermittent catheterization, and it really changed the morbidity mortality for this special group as we're going through. The Paralyzed Veterans of America put forward the consortium guidelines on bladder management for adults with spinal cord injury in 2006. A number of folks vet these guidelines. So as they put together, it wasn't just AAPM&R, it wasn't just spinal cord injury physicians, but it included psychologists, social workers, nurses, physical therapists, occupational therapists, recreational therapists. So there were a lot of people that contributed to these guidelines as we go through there. So as a starting point, basic anatomy. We have two major components of the urinary tract. We have the upper tracts comprised of the kidneys and the ureters, and then the lower tracts, which we're going to call the bladder, urethra, and sphincters. So as we look through those, and particularly to the lower tract, this is what allows us continence, that is, allows us to remain dry even when our bladder fills, at least under voluntary conditions. So Micturition is that process between bladder filling and emptying, and there's a number of components of the nervous system, including the cerebral cortex, the pons, the spinal cord injury, and then the peripheral nervous system as it's comprised of sympathetic, parasympathetic, and somatic innervations. And so we're going to talk through all of these aspects. Bladder filling is where you have primarily sympathetic over parasympathetic responses, detrusor relaxation, and voluntary external sphincter contraction. As opposed to bladder emptying, which the parasympathetic nervous system now exceeds the influences of the sympathetic nervous system to allow for detrusor contraction, whereas you have relaxation of the internal and external sphincters. So I'd like you to think about the lower urinary tract as a 2x2 system, either looking at bladder function or sphincter function. And with regard to bladder function, that is considered too much, so that you have neurogenic detrusor overactivity, or NDO, or too little bladder function, that is detrusor acontractility. Sphincter function, again, can be too tight, in which you have detrusor sphincter dyssynergia, and you develop a high pressure bladder because you cannot get through the bladder outlet, or too loose, in which you have incontinence because of intrinsic sphincter deficiency, or ISD. So as we look at this bladder balance, again, I'm going to be showing this on multiple slides as we come through. So on the x-axis, if you will, we're looking at bladder contractility being atonic or areflexic on the left side of the graph, and hyperreflexic or spastic, if you will, on the right side of the graph or the scales. And then we look at the y-axis as sphincter contractility, either being low or being high as we go through this. So you'll see this as we continue to talk through and how bladder innervation significantly modifies Bladder Balance. So as a starting point, remember that we've got the sympathetic nervous system, and it contributes to bladder function through the hypogastric nerve, components of T10, T11, T12, L1, and L2. Goes towards detrusor relaxation. That's beta 1, and we'll talk about beta 3 receptors, as well as bladder neck contraction through alpha 1 adrenergic receptors, and then the contribution to bladder storage. Parasympathetic nervous system, its influence is conveyed through the pelvic nerve, components of S2, S3, and S4, and it promotes detrusor contraction through cholinergic activities, that is voiding. And the somatic nervous system, that is the aspects that we have sensory and voluntary motor control over, conveyed through the pudendal nerve, S2, S3, and S4, which provides voluntary innervation to the external sphincter as well as to the pelvic floor musculature. So as we go through this, keep in mind the neurotransmitters. Pharmacologically, this is going to make a huge difference in terms of how we manage these different components. So up on the right, the sympathetic adrenergic receptors are the alpha 1, which basically are prominent at the bladder neck, and the internal sphincter of the urethra. Beta 1 and beta 3, primarily beta 3 receptors, adrenergic receptors that promote detrusor relaxation. And so again, sympathetic nervous system shouldn't cause voiding. It should in fact cause storage as we look at this. Parasympathetic nervous system, which is, remember, in a constant tug of war with the sympathetic nervous system. Neither one are all the way turned off at any given time in an intact nervous system. Parasympathetic release of acetylcholine can impact muscarinic 1, muscarinic 2, or muscarinic 3 receptors. That's M1, M2, or M3 receptors, not M20. And recognize that the rest of the body has quite a few muscarinic 1 receptors. The bladder is 80% muscarinic 2 and about 20% muscarinic 3 receptors. And again, these receptors, primarily muscarinic receptors 3, mediate the detrusor contraction associated with micturition. And then down on the right, we'll talk through the somatic cholinergic nicotinic receptors. And these basically allow voluntary activity of the external sphincter, which is again skeletal muscle. So now I'm going to try to, as we go through this, we'll keep sympathetic nervous system activity in red. And so as we look through this, again, looking at the hypogastric nerve, T10 through L2, sympathetic nervous system activity when we are filling the bladder is on, and so we see it increased, and we have relative bladder storage. During this time of bladder filling, the parasympathetic nervous system influences are markedly reduced, and so along the pelvic nerve, you have relatively few parasympathetic activation or activity going on, so that this is also going to contribute to detrusor relaxation, if you will, because you are not activating through parasympathetic nervous system the detrusor to contract. And then finally, you have increased activity of the somatic nervous system to the external sphincter and the pelvic floor musculature. Again, as the bladder relaxes, the detrusor relaxes, the sphincters contract to allow for storage and filling. So under these conditions, and again, I beat this to death, but it's important for us to understand each aspect as we're coming through this. So bladder filling, again, is facilitated through sympathetic nervous activity and somatic nervous activity that allows for detrusor relaxation. Bladder filling is not under significant influence of parasympathetic nervous system. So instead of detrusor contraction, with reduced parasympathetic activity, again, this allows for bladder filling. Now, as we talk about the opposite now, bladder emptying, now we're talking about a diminished sympathetic nervous system response along the hypogastric nerve. And so you have a decreased detrusor relaxation, that is an increase of bladder tone, if you will. Your parasympathetic influence predominates during bladder emptying, such that you have influences along the pelvic nerve, that is S2 through S4, that contribute to detrusor contraction primarily through muscarinic 3 acetylcholine receptors. And again, this is going to contribute to detrusor contraction. And then you have a relative relaxation of the somatic nervous system. So you have decreased activity along the pudendal nerve so that you have relative external sphincter and pelvic floor musculature relaxation. So again, looking back to our graph, we see for bladder emptying, that is for voiding, decreased sympathetic nervous system response and an increased parasympathetic nervous system response contributing to detrusor contraction, again, primarily conveyed through M3 cholinergic receptors. And you have a relative decrease of the somatic nervous system with a relative relaxation of the external sphincter and the pelvic floor musculature. And so in this scenario, you're squeezing the bladder and its contents easily flow through because you have very little in the way of bladder outlet obstruction. So two major components when we talk about spinal cord injury, two major components that we have to consider is an upper motor neuron bladder, which is going to be spastic, that is hyperreflexic, increased tone, and it's velocity dependent. And so in this condition, typically you have not just detrusor spasticity, but also pelvic floor and external sphincter spasticity, so that you end up developing high pressures, and those high pressures can ultimately lead to hydronephrosis, hydroureter, acute renal failure, and death. It can also contribute to spastic incontinence. As opposed to a lower motor neuron injury, as we see down around the cauda equina or to the pelvic nerve itself, this is a situation where you have a flaccid bladder and a flaccid sphincter. So it's not unusual to see overflow incontinence. And on the picture here, if I can get my arrows working, this represents what Dr. Ed McGuire at University of Michigan would call a small evil bladder. This is a contracted bladder. It is fairly inelastic, and it's because of increased tone over a period of time. Just like you would see contractures develop in upper extremities, or let's say for the hamstrings, for example, after spinal cord injury, that increased tone over a period of time decreases the number of sarcomeres in series and leads to a much smaller and contracted muscular state. Whereas the lower motor neuron areflexic bladder, generally speaking, is large and boggy, and the sphincter is, again, flaccid. And so you end up developing this overflow incontinence, which can also be problematic. So again, beating this to death, bladder pharmacology. I want you to remember that your cholinergic receptors, while you've got 80% M2 receptors, it's the M3 cholinergic receptors that contribute to detrusor contraction. And so selective control of those receptors is going to be important for us to manage or to help control bladder relaxation. The sympathetic nervous system to the detrusor is going to affect primarily the beta-3 adrenergic receptors. And again, this contributes to relative relaxation, as well as alpha-1 adrenergic receptors at the internal sphincter, the trigone of the bladder. and then you have the somatic nervous system, which releases acetylcholine, which then interacts with the nicotinic receptors. And so from a diagnostic standpoint, we need to be assessing soon after spinal cord injury, and then intermittently, at least at 1 year increments. We're gonna be looking at laboratory, nuclear scans, renal ultrasounds, abdominal CTs may be required, cystoscopy, urodynamics, and voiding cystourethograms. So the top portion of this is essentially looking at upper tract, and so our renal panel is going to give us information about the glomerular filtration rate, and we look at BUN and creatinine just kind of as a guide to let us know if we're having worsening or if potentially renal function is improving. We can look at creatinine clearance. Generally, cystatin C is a better representation because it's independent of skeletal muscle mass. And then we can obviously look at urinalysis, culture, and sensitivity for the possibility of urinary tract infections. Nuclear renal scan can tell us approximately how active each kidney is, the right versus the left. And that could be important, particularly as some folks with spinal cord injury will lose renal function over time because of hydronephrosis potentially, or because of stones and obstructions. Renal ultrasound is going to allow us to assess the integrity of the upper urinary tracts. And typically this is going to be done annually because bladder status can change. We'll talk through that a little bit more as I continue. An abdominal CT can be helpful when we're trying to assess the system for obstructions. So it'll tell us information about bladder calculi, ureteral calculi, and in fact, renal calculi. Cystoscopy allows us to look inside and look at the bladder. This is important especially for those folks who have chronic indwelling catheters because they're at high risk for developing stones as well as cancer, and particularly transitional cell carcinoma for those who have a urethral catheter in place. Urodynamics typically will be annually or biannually, and again, this allows us to assess pressure gradients between the lower and the upper tracts, and then our voiding cystourethrogram, and this is going to allow us again to determine pressures and risk for upper tract deterioration over time. So these are our main assessment tools. Particularly, we worry about compromising renal function, and so we're typically going to be using abdominal ultrasounds or renal ultrasounds, basically to determine if we have hydronephrosis. Now, hydronephrosis is what happens when you have high pressure within the bladder, and it subsequently causes the urine to go back up through the ureters and into the kidneys, potentially causing compression of the calyces and the functional units of the kidney, the nephrons. So the other thing that we will typically do is to look at urodynamic studies. These are assessing primarily the lower tract, that is the bladder, the sphincter, and the pressures within the bladder and the sphincter. Sorry, I jumped ahead there a little bit. So I want to make sure that we maintain bladder pressures, ideally under 40 centimeters of water. As we fill a bladder, so the way urodynamic studies are done is you have a catheter with a pressure transducer in the rectal vault, in the bladder itself, and then we're also looking at EMG activity as we go through this. Usually, normal individuals, as the bladder fills, there's relatively little change in the pressure dynamics until you get to a volume exceeding 300 cc's, and then you start to see a relatively high increase. But up until that point, you can see that generally speaking, you're keeping pressures within the bladder down around 10 centimeters of water. Why is that pressure gradient important? Because we know that at pressures of 40 centimeters of water or more, it changes the configuration of the ureters as they come into the bladder at an angle to allow them essentially to open up and forces urine back up the ureters and into the kidney. So a normal, an intact neurological specimen, if you will, would be able to initiate a void when asked to, and during that time you're going to see a relative increase in pressure as the detrusor contracts and the bladder outlet relaxes. When you do this, you should see EMG activity to the pelvic floor musculature, to the external sphincter stop abruptly as it relaxes. And then during the emptying, you ask the person to stop emptying, and you see an increase in EMG activity, again, reflecting the external sphincter and the pelvic floor musculature. During this time, the pressure within the bladder is going to relax as you have a relative relaxation. And then the person can go ahead and they'll be asked to restart the flow again, and we'll be looking at changes in pressure during that time. So the key thing here is voluntary control over the external sphincter and pelvic floor musculature, as well as changes in pressure related to detrusor contraction. The problem with an upper motor neuron bladder, that is a spastic bladder, is that as you fill, you start to see increases in contraction of the bladder. So the detrusor, as it fills, has stretch receptors, and those reflexes go all the way back to the cord and back to the detrusor along alpha motor neurons in a way that actually causes a spasm of the bladder. This is worsened when you have spasming of the sphincters and or pelvic floor musculature at the same time. When both sphincters and detrusor contract, the pressure is going to increase, and the only way that the urine can flow is back up through the ureters and potentially into the kidneys themselves. And so you end up with what we call bladder sphincter dyssynergia. Usually as you have contraction of one, you have relaxation of the other when the neurological system is intact, or you have relaxation of the one and contraction of the other. And so the occurrence of both of them at the same time is going to generate high pressures because you have lost the coordinated reciprocal innervation that we typically see under neurological normal conditions. So this is what the urodynamic graph looks like. Again, we're going to be looking at the pressure dynamics in centimeters of water that are appreciated in the bladder catheter. Again, you're going to have a pressure transducer on that one. You're also going to have a pressure transducer in the rectal catheter. And when you subtract out the vesicle from the rectal, you end up with what we call the true detrusor pressure. And again, we're wanting to see this pressure maintained below 40 centimeters of water. Pressures above that generally are associated with hydrouret or hydronephrosis. That is upper tract deterioration and putting your kidneys at high risk. So an upper motor neuron bladder, basically this is one is where you have disinhibition. You've lost the inhibitory input and the reflexes occur unchecked. So you have afferent influences from both the detrusor as well as the external sphincter. I've lost my arrow. And those afferent stretch receptors send information back along alpha motor neurons to the bladder as well as to the sphincter. And so this is that situation where you develop high pressure bladders greater than 40 centimeters of water, and you end up with upper tract deterioration. The opposite side of this is when you have lower motor neuron bladder, that is areflexia. So in this situation now, you've lost the integrity of the reflex pathway, Sherrington's final common pathway, to both the sphincter as well as the pathways for the detrusor. And so whether you've lost afferent, efferent, or both, the result is that you don't have the ability to contract the bladder voluntarily or through reflex activity. And so typically you're going to see bladder pressures under 5 centimeters of water, and as it achieves approximately 5 centimeters of water, your sphincter leaks as well, and you end up having the situation of overflow incontinence. So these are the main two types of bladders that we deal with as we look at spinal cord injury and cauda equina types of syndromes. Now, I've talked before about autonomic dysreflexia, and you remember that the #1 cause of autonomic dysreflexia in persons with spinal cord injury is bladder dysfunction. Anthony Bowlby first reported autonomic dysreflexia back in 1890 as a massive sympathetic outflow in response to a noxious stimuli below the level of spinal cord injury in folks with injuries above T6. And the complications could be stroke, seizures, organ failure, and yes, death. So now we've got a situation where we have one of these small evil bladders, high pressure generating. This would be painful if the person could experience pain, but because they lack sensation, instead what happens is you have an ascension of these afferent signals blocked at the level of the spinal cord injury and a reflex outflow causing splanchnic vasoconstriction and subsequently hypertensive crisis. Increased pressure is sensed by baroreceptors sent to the medulla, which sends information back to the heart to cause a relative bradycardia. But below the level of the injury, you remain vasoconstricted. Above the level of the injury, you end up with flushing, sweating, and this pounding headache we call autonomic dysreflexia. So, urological causes of autonomic dysreflexia include bladder distension, bladder calculi, renal calculi, not trigger geometry, by the way, urinary tract infections, bladder spasms, trauma, and cancer can all contribute to autonomic dysreflexia in persons with spinal cord injury. Recognize also that a person who distends their bladder more than 500 cc's, for example, is going to cause significant microstructural tears within the detrusor. And that would be painful, and it will continue to be painful and cause bladder spasms until those are subsequently healed. So we've got a number of reasons why we need to control this lower tract system and prevent high pressure situations, prevent high volume situations. So our typical goals of bladder management are going to be to preserve the upper tracts, that is the ureters and the kidneys. We want to prevent infection and the development of calculi or stones either in the bladder or the ureter or the kidneys. We want to maintain urinary continence, and all of this is going to contribute to quality of life and patient satisfaction. So these are the goals that I want you to continue to be thinking about as we progress through this talk. We know about assessment of the bladder system, the upper tracts and the lower tracts. Now we need to talk about management strategies that are going to contribute to urinary continence, improved quality of life, and to make sure that we preserve upper tract as we go through there. Now this is probably the most important slide of my whole presentation. People with spinal cord injury, when asked what is their highest priority, if we could change something for you, what function would be the most important? And Kim Anderson, while she was here at the Miami Project, reported out in 2004 in a survey that included over 600 individuals, what is most important to you? Arm or hand function, upper body or trunk stability, bladder bowel dysfunction, sexual function, chronic pain, normal sensation, or walking. And individuals with tetraplegia, almost 50% said arm and hand function is going to be most important if I could get something back. Sexual function is next high on my list, followed by truncal stability and bowel and bladder management, including prevention of autonomic dysreflexia. Persons with paraplegia, their highest priority, if you look over at the graph, their highest priority had to do with sexual function. And we'll talk about sexual function in a couple of weeks. But their second highest priority was bladder and bowel management and the prevention of autonomic dysreflexia. When you combine the two groups, tetraplegia and paraplegia, the highest priorities when you combined all of these were the restoration of sexual function and the ability to manage bowel and bladder. Those were the highest priorities reported back around the turn of the century and continue to be some of the highest priorities for persons living with spinal cord injury. So our bladder management should be conducted. Ideally, this would be evidence-based. Last month, Journal of Spinal Cord Injury Medicine put forward a couple of manuscripts talking about the importance of preclinical and clinical outcome metrics because this is such a high priority for persons with spinal cord injury. So the preclinical research, that includes animal models, is looking at tissue morphology, voiding dynamics, cystometry with or without EMG, and metabolic cages that would allow us to keep track of ins and outs, fluid ins and outs for those animals. With the hope that we could translate those preclinical outcome metrics to clinical outcome metrics. And so again, you're going to see some very similar types of things. Most animals aren't keeping their own diaries, but we would like to keep track of their I's and O's, how often they're voiding on a daily basis, and if they're having episodes of incontinence. Physical exam and laboratory findings are also important. Clinical outcome metrics in research should also include imaging studies, uroflowmetry, post-void residuals and urodynamics, and uroscopy. I'm having a hard time saying this. Subjectively, this is what animals can't report, and that is what is their quality of life with a spinal cord injury with regard to bowel and bladder function. And so it is recommended that when doing clinical research, we also report out quality of life scales that are self-reports, either the Qualavine 30 or the short form Qualavine forms, as well as providing information for the International Lower Urinary Tract Function Basic Data Set. Acute bladder management options. So for all of the medical students and medical residents, I guess, and attendings, we need to make sure that we are taking full advantage of these bladder orders. And so in Cerner, we are making sure that we have these options available to you, and it's important that you choose one or more of them when you're writing orders for your admissions for a spinal cord injury patient. Ideally, we'd like to discontinue the indwelling catheter once the daily urine output is less than 2,500 cc's, and replace that with an intermittent catheterization protocol, ICP. Ideally, in the hospital setting, ICP is done with sterile technique by the nurses, typically every 4 or 6 hours. We need them to document the volumes and then contact the house officer for volumes greater than 500 cc's, because that could contribute to urinary tract infections, incontinence, and autonomic dysreflexia. For persons with incomplete spinal cord injury, again, intermittent catheterization protocol with sterile technique is appropriate, but now we're going to be using lidocaine jelly every 4 to 6 hours, as well as documenting the volume. For individuals who have had a sphincterotomy and or a urethral stent, an external catheter is appropriate, again, documenting 24-hour urine output. I don't like to use indwelling catheters, but if I don't have other options, then you want to put the orders in and again have the nurses document 24-hour urine output. If I've got to use an indwelling catheter and it's going to be chronic, I would prefer using a suprapubic catheter because it's less likely to cause stones or transitional cell carcinoma. So again, documenting 24-hour urine outputs. And then we want to provide, when appropriate, voiding trials. So your orders are going to look like this. You're going to offer the urinal Q4 or 6 hours, documenting the volumes. And it's very important that you document post-void residuals, volumes, and intermittent catheterization is required for post-void residuals greater than 50 cc's. Once your PVRs have been documented 3 times with volumes of less than 50 cc's, you can discontinue around-the-clock intermittent catheterization, but keep tabs, because as spasticity, skeletal muscle spasticity increases, that may also change the person's ability to voluntarily void. So, intermittent catheterization protocol, again promoted by Ed McGuire in the 70s, 80s, who's a neurourologist at the University of Michigan. The ideal is to do intermittent catheterization so that you don't have an indwelling catheter. The indwelling catheter contributes to the development of bladder and renal calculi, contributes to urinary tract infections, and contributes to transitional cell carcinoma. Therefore, intermittent catheterization will hopefully reduce all of those. The goals of intermittent catheterization is to keep the bladder volumes less than 500 cc's and ideally under 400 cc's, maintaining post-void residuals between 50 or 100 cc's. Usual practice in the hospital setting, in the acute rehabilitation setting, is with sterile technique because you may have multiple nurses doing the intermittent catheterizations and you don't want to be introducing new bacterial flora. At home, ideally, the person is going to be able to use a clean technique that doesn't require sterility. And the really ideal situation is to use touchless catheters. Again, the ideal situation here is the low friction touchless catheters that are going to be less likely to cause urethral damage. Intermittent catheterization protocol is desired for anybody who has sufficient hand skills and or those with caregivers that are willing to do it. Recognize that generally speaking, a person with C6 tetraplegia could do intermittent catheterization by themselves, provided appropriate assistive devices. However, if they don't have those assistive devices available to them, most would need finger flexion and thumb flexion voluntary control to be able to manage the catheter independently, and that would be at a C8 level. So this is the ideal. You'll consider alternatives if the person has abnormal urethral anatomy with strictures, scarring, or acute urethral trauma. If their bladder capacity is less than 200 cc's, then you would have to cath them approximately 10 times a day just to keep them from overfilling and causing autonomic dysreflexia. If they are unable or unwilling to adhere to an intermittent catheterization protocol, that's going to put them at high risk for high pressures and autonomic dysreflexia. If they have a high fluid intake, greater than, say, 3,000 cc's a day, if they have a tendency towards autonomic dysreflexia with bladder filling, and or if they have adverse reactions to just passing the catheter multiple times a day. So when you do intermittent catheterization, there is the potential for urinary tract infections, bladder overdistension, urinary incontinence, and urethral trauma. Autonomic dysreflexia associated with bladder distension and high pressures, and or bladder stones. But the risk for all of these is less using intermittent catheterization than if you have an indwelling catheter. Now, just briefly talking about the definition of a urinary tract infection for persons with spinal cord injury. Most folks will develop a significant bacteriuria and usually that's okay, that's colonization, unless the person experiences significant pyuria, so white blood cells in the urine associated with nitrites and Luke esterase positive activity, and have signs and symptoms that could include fever, rigor, pain, malaise, autonomic dysreflexia or spasticity that is new, cloudy or odorous urine, or new incontinence. So these are all, we want to see these, we want to evaluate these before we provide a diagnosis of a urinary tract infection, because over the years we're likely to develop superbacteria, that is antibiotic resistant bacteria, if we treat them willy-nilly with antibiotics when they didn't really need it. Most folks, again, will develop an asymptomatic bacteriuria, whether that's a collection from intermittent catheterization, external catheter, or indwelling catheter. Asymptomatic bacteria is not a urinary tract infection and does not warrant treatment with antibiotics unless the things on the previous slide were present. Significant pyuria, nitrite positive, Luke esterase positive, and or those symptoms, including fever, rigor, pain, incontinence, autonomic dysreflexia, and or spasticity. For those folks who are developing recurrent urinary tract infections, the differential diagnosis is going to be that you've got bacteria simply hiding themselves in the indwelling catheter, and once the bacteria is gone, then they re-emerge and repopulate. It could be related to catheterization technique. It could be related to bladder or renal stones. Stones are very, very porous, and bacteria can actually climb up and hide in the porous areas of the stone. Again, once antibiotics have been stopped, those bacteria will again propagate and develop into another urinary tract infection. And or if you have bladder diverticulum, that is, you have these little out pockets where your bacteria can hide just like they would with bladder calculi. Now, prophylaxis is not routinely indicated. There is some literature, but the evidence basis is not strong to use mandelamine or nitrofurantoin or cranberry tablets as prophylaxis. However, we don't have evidence basis that this is good clinical practice. There will be times where you may try these things if the person is not wanting to move to the next steps in a treatment protocol. Generally speaking, however, there again is not evidence basis for using these agents as prophylaxis. Crede and Valsalva maneuvers is simply applying suprapubic pressure to express urine from the bladder. You can also have the individual try a Valsalva maneuver, again contracting abdominal muscles when they can against a closed glottis to increase abdominal pressure and help to evacuate the bladder. Consider this for folks who have lower motor neuron injuries, low pressure and low outlet resistance, or those who have sphincterotomies. Typically, you're going to be using a collection device like an external catheter. Don't use this as a primary method for emptying the bladder if you have upper motor neuron hyperreflexic bladder and sphincter. You also, again, avoid this for individuals with DSD and bladder outlet obstruction, BOO, vesicoureteral reflux, hydronephrosis, autonomic dysreflexia, or expanding syrinxes. Consider indwelling catheters as a last resort. So for those individuals who have poor hand skills and don't have a caretaker to perform intermittent catheterization, those who have a high fluid intake, cognitive impairment or substance abuse that would prevent them to follow a typical around-the-clock schedule. Those with elevated bladder pressures may simply need this indwelling catheter, recognizing that the catheter itself can contribute to higher pressures as well. Again, if you have recurrent urinary tract infections, consider a hydrophilic catheter or silver impregnated indwelling catheter. Typically, when we talk about indwelling catheters, we're thinking about urethral catheters, but I would like you to consider, if you have to use an indwelling catheter, to go suprapubic instead. Okay, so this is, you're actually going through the abdominal wall, placing the catheter and the balloon in the anterior portion of the bladder rather than through the urethra. This is going to put you at less risk for urinary tract infections, for bladder stones, and for bladder cancers. So again, recognizing nonetheless indwelling catheters have inherent risk for stones, urethral erosions, epididymitis, recurrent urinary tract infections or pyelonephritis, and autonomic dysreflexia. Consider reflex voiding. This is not my method of choice, but for those individuals with adequate bladder contractions and the ability to use condom catheter, who have poor compliance with fluid restrictions, small bladder capacities, and small post-void residuals. The danger of doing reflex voiding is increasing pressure within the bladder, therefore contributing to ureter, hydronephrosis, acute renal failure, as well as autonomic dysreflexia. So always do a urodynamic evaluation and provide other options as preferred to reflex voiding. These complications go along with reflex voiding, and it's no small thing to develop autonomic dysreflexia, stroke, and death. So the rest of the time, I'm going to speak through a little bit of pharmacological intervention and then talk about surgical options. So we'll talk through alpha blockade, antimuscarinics, and the use of botulinum toxin as we're managing this. So alpha blockers, again, these are going to help to open the urethra near the prostate and cause relaxation of the trigone of the bladder where you have the alpha-1 adrenergic receptors. Avoid use in persons with symptomatic hypotension because alpha blockers also cause a reduction in blood pressure. Therefore, if I'm going to be using this, I encourage them to take their first doses at night while they're supine, where it's going to have less influence on their blood pressure and subsequently cerebral perfusion. And be very careful if you're going to be using alpha blockers and erectile dysfunction drugs, because again, you can put somebody into a syncopal episode as their blood pressure drops. So the bottom line is there's a number of different options for using alpha blockers. All of these have been demonstrated to be helpful: terazosin, phenoxybenzamine, tamsulosin, prazosin. The first and the last on the list are probably go-to medications for the most part. Phenoxybenzamine, while it works great, is also very, very expensive, and tamsulosin is also fairly expensive compared to terazosin and prazosin. And I'm stuck. So when we talk about anti-muscarinic, that is parasympathetic therapy, recognize that we are looking for selective agents for the M3 receptors. So recognizing the M2 receptors, while most prevalent, aren't the ones that actually trigger the bladder contraction. Those are the M3 receptors. So when you have an agent that is non-selective, that is, it hits the M1 and M2 receptors as much as it does the M3 receptors, you're going to have more side effects. And the side effects for all of these medications include dry mouth, blurred vision, constipation, and potentially CNS effects. I guess keep in mind that the newer anti-muscarinics are more selective, but more expensive as you go down the list. And so generally speaking, let me go back to this, those you can get sometimes good response to oxybutynin, but you have high side effect profiles, a lot of dry mouth, a lot of constipation. And so typically I only use this as a bridge And when the person tells me that they're not tolerating it well, I have a low threshold to move to one of these other agents. The relative expense of these agents is shown, recognizing that at least you're moving to once-a-day dosing most of the time, and you have fewer side effects associated with it, but relatively high cost. And in fact, Yamada's group had reported out the relative efficacy of each of these. There was recently a study done comparing the cost effectiveness of botulinum toxin to these other agents. And although botulinum toxin is more expensive, generally speaking, it's a much better agent, and in the long run is actually less expensive than using those antimuscarinic agents over time. So consider sphincter injection. For those with Detrusor sphincter dyssynergia, consider injecting the Detrusor as necessary. And typically you'll have a response to this of 3 to 6 months. And again, Murray is the one that showed the comparative efficacy and the cost benefit of using Botox as opposed to other pharmacological agents. There are limitations. You don't want to use it all the time, and potential complications, so keep that in mind. Endourethral stents basically hold the urethra open and are used for those folks who have significant bladder outlet obstruction that can't be managed otherwise. The problem with this is that you're going to be wetting yourself essentially to external catheter, external appliance as you're moving forward with this. Sphincterotomy, so the transurethral resection of the external urinary sphincter, is basically very similar, but it causes more scarring, and so a lot of times the scarring will cause you to have to go back and redo this, and most of the time now they're placing endourethral stents in place of the sphincterotomies. Again, a person is going to be wed to a condom catheter as you go through this. Electrical stimulation can be used, is no longer available within the United States, except under experimental conditions. The Vocare Ballon bladder system, put forward by Neurocontrol, basically wasn't cost effective enough, and with the relatively few users and its relatively high cost, was not a good option for our folks with these in place. Bladder augmentation is a possibility where you actually sew a portion of the intestine into the bladder to make it larger when you have these small contracted evil bladders that Ed McGuire is so concerned about. This will significantly reduce bladder pressure and can be combined with an abdominal stoma. You can have a continent urinary diversion, and depending, this can take place of the bladder itself, and so you tie the ureters directly into this stoma so that you can have either a ileovesicostomy or a ureteroileostomy, and then recognize the Mitrofanoff Appendicovesicostomy. And again, this is for those folks who just want to cath through the belly button. They develop a channel there with a little flap that closes when your bladder fills, and then you pass the catheter in to empty the bladder as you're going through there. So I know that that was a very, very quick talk through bladder management strategies. I have a few minutes. I'll stay on for questions or thoughts, concerns, or if you have additional therapeutic management strategies, I would love to hear those now. Either everybody fell asleep or I did a fairly good job going through this. Thank you for those of you who stayed on and participated through. I'll give you another couple of minutes in case something comes to mind, but I greatly appreciate your participation. There's the chats I was looking for. Sorry, I missed these earlier as they were going through. And they're all just areas of gratitude. Well, thank you very much. I'm going to go ahead and close this down. Again, these will be available online through the Miami project at some point in the future. Everybody have a great day.